Hi, and welcome to the McGregor Dementia Support Ministry Podcast, a podcast providing relevant resources to those currently walking the dementia journey with their loved ones. Today's podcast is a session that was recorded from our Alzheimer's and Dementia Seminar held here at McGregor Baptist Church on February 22nd, 2025. Today's podcast session is titled Navigating the New World of Alzheimer's Disease by Dr. Benjamin Mast.
Thanks for the warm welcome, and thanks for having me back. This kind of program and this specific program here is just a dream, that churches would be invested in caring for people with Alzheimer's disease and other dementias, and the people who take care of them, their caregivers or care partners. We're on a tight schedule with things today, so I'm actually going to jump right into my material with you today. So I'm going to be giving you two things this morning. I'm going to talk a general, quick overview of what Alzheimer's disease is, and then I'm going to jump into some changes that have happened in the way that we think about Alzheimer's, the way we make a diagnosis, and the way we think about treatment and intervention. For many years, nothing seemed to change in Alzheimer's disease, and in the past couple of years, and even in the last year since I was here, a lot has changed. And so I want to talk through those with you. Now, before I do, I just want to say my goal is not to tell you what to do next. I can't do that because your situations are unique and you're unique, and you should make those decisions based on who you are and what you believe and what's important. But I do want to give you some information on this dizzying array of changes in the Alzheimer's world so that you can think about it with your family about what you would want for you. So let's jump right in. One of the key questions that we have to think about is what's the difference between Alzheimer's disease and dementia? And like I said, I'm going to move quickly through these things. We do have time for Q&A later today. You can catch me during lunch. I'm happy to try to answer more questions, but we won't do that during this time or we will never stay on track. So what is dementia and how is it different from Alzheimer's disease? Probably the most common question I've gotten over the last 20 years. The first thing we have to understand is dementia is not a disease. Dementia is a functional category that we just use to describe when people have declined in terms of their memory, their cognitive functioning, to an extent that it interferes with their independence, right? It's not normal aging. Really, we're talking about a change that limits people's ability to do the things that they used to be able to do. There are many causes of dementia, and Alzheimer's disease is one of those causes. Now, a bit later, Dr. Shaw is going to talk to you about some of these other types of dementia, but just to say now that dementia is a broad category, and there are many specific types, and Alzheimer's disease is one of them, and it's the most common cause of this syndrome that we call dementia. So I'm going to spend some time on what we know about Alzheimer's disease. All of this is classic Alzheimer's knowledge. This has not changed in probably 20 years. Then we'll jump into what's changed in the last few years. So you're probably familiar to some extent. Alzheimer's disease comes on very gradually. Typically, the first symptoms that people experience are in short-term memory loss. Asking the same question over and over, forgetting conversations, maybe forgetting names. And one of the difficulties of Alzheimer's disease, it's progressive. That means it gets worse over time. What we now know about Alzheimer's disease is that it is caused or associated with some very specific changes in the brain that I'll explain in a moment. And when I say it comes on gradually, that's a real understatement, right? So these changes are present in the brain probably 10 to 20 years before people start to show symptoms. So when it's hard to recognize in its earliest stages, or maybe people in the same family don't agree as to when it started, that's not surprising. It's very, very subtle at first, but it gets worse over time, unfortunately. So I'm going to give you this very quick overview of what these changes are, because they're very important for how things are changing in terms of thinking about Alzheimer's. The first change is what is the development of amyloid plaques. So these are tiny microscopic changes in the brain. There are 3 images here. It's not particularly important that we look at them. I don't think my pointer is quite working. But you see 3 images here. The first is on the far left. That is amyloid precursor protein. It's these little blue squiggly lines. This is a normal part of a brain cell, and in Alzheimer's disease, for some reason, an enzyme acts upon that protein, snips it into fragments, and shows up on the far right as a plaque that exists between those brain cells. It disrupts their communication, and it leads those cells to die. Okay? We think this is the earliest change in brains of people with Alzheimer's. The second change actually happens within the cell. This is the development of what we call neurofibrillary tangles. It's associated with a different protein called tau. There's an internal support structure in every cell. It's like a little train track that transports nutrients. In Alzheimer's disease, that support structure falls apart. It can't transport nutrients, and there's a second cause of cell death in brains of people with Alzheimer's. We've known this for a very long time, that this is a key part of that disease. Along with that, when that cell dies, that tau protein clusters together into what's called a neurofibrillary tangle. So I know that's a lot of technical details very quickly, early in the morning. The coffee maybe even hasn't kicked in yet. I just want you to remember plaques and tangles, amyloid and tau. You're going to hear those over and over with me today. So when we say that this leads to cell death in the brain, it leads to significant shrinkage or atrophy of the brain tissue. So you're looking at a healthy aging brain on the left, an advanced case of Alzheimer's disease on the right. Okay, so very significant damage to the brain over a period of many, many years, gradual. We're going to come back to this image in the afternoon session and talk about what does it mean to live with this level of damage in the brain, and how do we make sense of this in terms of people's life and faith. So we have these changes, the plaques and tangles, amyloid and tau. I said those begin many years before people show symptoms. In this particular image, you see people declining into dementia. It's a departure from normal aging. And there's this long period of time that we call the preclinical period of Alzheimer's disease, where the brain is changing and people have no symptoms, right? So the plaques and tangles are developing in the brain. The brain is starting to be damaged, but people are functioning completely independently. There's no memory problem. They're functioning totally fine. I could be living with the plaques and tangles and be talking to you relatively clearly. That's the idea, right? It can be there many years before people show symptoms. This is an important idea in terms of what's changing in Alzheimer's disease, and it creates some interesting and difficult problems and opportunities. Okay. So as people live longer with Alzheimer's disease, that pathology continues to spread throughout the brain. And as that happens, people's memory and their thinking and daily functioning continue to decline. Right? So when we talk about Alzheimer's, I probably don't have to tell you there's a lot of difficult things we encounter, and this is one of them. Alzheimer's progresses. It does get worse, at least in terms of functioning. All right, so as people live longer with it, we can expect that they will need more help from other people. They'll become more dependent on other people for things that used to be very easy for them to do. The treatments that we have for Alzheimer's disease, I'm going to talk about the old treatments first. We still don't have a cure, right? We've said that for many, many years. There's still no cure for Alzheimer's disease. Now, a lot is changing, but let me talk about the old medicines first. For many years, people received what we call symptomatic treatments for Alzheimer's disease. These are things like Aricept, Namenda, Donepezil, the things that your doctor or nurse practitioner gives as soon as somebody starts to have a clinical memory problem or another dementia. These medicines were really designed to boost certain chemicals in the brain to help enhance memory and cognitive functioning. They were not designed to do anything about those plaques and tangles, the amyloid and tau that we talked about a moment ago. These medicines are well known. People take them all the time. They have a relatively low side effect problem. Sometimes people get GI distress. They'll get bad nightmares, which if you're having them, that's a real significant side effect. But they're safe medications we've used for a long, long time. And when I say we, I mean the medical profession. I'm just a psychologist. I'm not a physician prescribing anything to you, right? But these were just focused on symptoms. They were not designed to modify the disease itself. So the best and fairest way to describe the effect of these medications is that some people respond better than others, and some people get a modest benefit for a period of time. But everybody who was invested in Alzheimer's treatment really knew that this was not what we were hoping for in terms of a medication for something that can be as difficult as Alzheimer's. So that brings us to the new developments in the world of Alzheimer's disease. This is changing so fast that sometimes I can't even keep up with all the new developments. And that's a very good thing. But as we start in, again, I want to just highlight, you're going to be encountering some things as I'm talking you through this today that might be a bit confusing, and you're not sure that some of these new developments are even ones that might help you in your individual situation. So it's wonderful that we have many new developments, but they take a lot of thought and wisdom to think about how they might apply in our individual lives. So we're going to talk about changes in treatment, new developments. We're going to talk about new developments in detection and diagnosis. And then we're going to wrap up with new developments in prevention, which is probably the most positive thing that I'll talk about with you today. So, new treatments, all since 2021, and one of these within the last year. So a couple moments ago, I just said, most of the treatments that are FDA approved and available for you have been symptomatic. That means they're just trying to boost symptoms. Wouldn't it be nice if you actually had a treatment for Alzheimer's disease that attacked the underlying process, those plaques and tangles, the amyloid and tau, right? That's been what people are aiming at for a long time, and it has finally arrived. So these new treatments are actually infusions. These aren't pills. I understand within the year they might become injections, but they are designed to remove those amyloid plaques from the brain and perhaps keep them from building up again. So that's an amazing development in terms of Alzheimer's disease. You may recall less than 10 minutes ago I told you amyloid plaques were the earliest changes in the brains of people with Alzheimer's disease, and now we have 2-3 different medical approaches to removing them from the brain, and they do that. They're remarkably good at removing amyloid plaques from the brain. That is one of the 2 key changes in the brains of people with Alzheimer's disease. Thank the Lord for that. That is a very good thing. So there are 3 of these that have been approved by the FDA, and one of them has been pulled from the market because, frankly, the other 2 are better, right? And these are good at removing amyloid, but they haven't been quite as good at improving memory, right? So I'm going to show you some data in a moment, and we'll talk both about the benefits and the potential risks of these infusions. Let's just jump right in. So this is going to be too small to see, but you have it in your printout, as Pastor Mark said. All you're looking at on these 2, these are data from the most recently approved infusion from last summer. You've got 2 lines. One of them is in gold. It would be the top line. I keep pretending this is going to work and point at, but the top line is the treatment. the bottom line in each of them is the control, people who don't get the infusions, all right? There's a lot of data here. I don't want to go through all of it, but you don't have to be a scientist to see there's clearly a difference between those two things, right? The people who are getting the treatment are functioning somewhat better than the people who aren't. That's one of the things that I want you to see. So it works in terms of clearing amyloid, and there is a difference in functioning. One of the companies that is marketing these suggests a 30% slowing in the progression of Alzheimer's disease. Right? On the other side, I also want you to see, and you can see it yourself, even though there is a difference, you can see that there is still some progression of the decline in function. Right? So while these are a step forward in terms of modifying the underlying disease, or at least half of it, the amyloid part, not the tau part, it's doing that. But what I want for you and what I want for people that I interact with about Alzheimer's disease to have is an appropriate set of expectations about what's going to happen, right? It isn't quite the case that you take these infusions and you go back to where you were before the Alzheimer's started, right? And so it's positive, but the question is how positive. And keep in mind, these are group averages, right? So some people are responding better than others. On the other side, there are some risks associated with these infusions. And so as people are studying these infusions more and more, they're understanding these side effects a bit better and how to avoid them. And these fall under a term that's called ARIA. It's an acronym, but it's basically a term used to describe brain swelling and little micro bleeds in the brain that can happen when people take the infusions. So it does happen, less than 20% of cases. These scientists and drug companies are better understanding who's at risk for these negative side effects. But it's important that you understand that this is part of it, right? Because with the old medications, you could take your prescription for the pill and you'd go home and you'd take it each day or have somebody help you remember to take it each day. With these new infusions, as we try to better understand the swelling and the bleeding that can occur, you have to be monitored to keep an eye on those. So if you go on the infusion, you need to be able to have brain MRIs to look for the swelling and the bleeding, right? They aren't going to just send you off and let you, just wonder if these things are happening. They're going to monitor for it and respond appropriately. But when you're thinking about these approaches to treatment, you have to understand that this is a part of the process, right? So we're still learning a bit more about ARIA, and when I say we, I mean the broad medical research field. But this isn't part of what we're thinking about. And so you and your doctor and your family will make decisions about whether this is a good treatment for you. You'll want to ask questions about these types of things. There are certain types of people who have higher risk for the negative side effects. So there's a genetic risk factor called the ApoE4 allele. You maybe have heard of it if you follow Alzheimer's. People who have 2 copies of that allele have higher risk of these brain swelling and bleeding. Right? So they may want to do a bit of genetic testing. I know it's a lot to take in. There's a few more things about the treatment. Currently, it's available for people who are either early Alzheimer's, early stage, or who have mild cognitive impairment. That's a term we use to describe people who have cognitive impairment but still function independently. So if it's moderate or severe dementia, currently you can't get this treatment. It's really designed for early stage to try to slow down the disease process. Second, you have to have positive evidence of amyloid. You're like, well, how would I get that, right? You said these tiny microscopic changes. We're going to talk about that in a minute, right? There's ways now that we can detect those changes in the living brain. This treatment is not for the other dementias. I said Dr. Shaw is going to talk about some of those other types. This is restricted to Alzheimer's disease and people who have definitive evidence of Alzheimer's in the brain. And we'll talk about how they do that in a moment. You have to be able to have MRIs, right? So if you have a pacemaker or other implants that keep you from having an MRI, you might not be eligible for the treatment. Any of these you're going to need to obviously work with your healthcare provider to pursue. So is this a game changer, right? You'll get different opinions on that, right? Well, until these came out, we hadn't had a new Alzheimer's medication approved by the FDA since 2003. That's an incredible amount of time. So 20 years, roughly, without a new medication. Compared to cancer, there are 15 to 20 new medications every year. So I'm quite thankful that we have new treatments that are on the market and are moving us forward in terms of our understanding of how to treat this disease. We looked a little bit at those lines that showed the benefits. Some people are more impressed with those benefits than other people, right? Some people look at that and they say, that looks pretty good to me, and other people say, is that it, right? And you'll make these decisions based upon what you want, right? So do you want to do anything that you can? And some people feel that way. I would take any treatment I could get for myself or my loved one that could do anything to slow it down and maybe buy us some more time, right? That's kind of the focus of the treatment, is not currently a cure, but could it give us more time, more clarity, and more time at home, perhaps, right? So there are going to be some future applications. Obviously, we're thinking about how could we do this earlier and earlier, and one of the things I'm going to touch on in about 10 minutes, hopefully, is will they start using this in people who don't have symptoms, right? We said those changes begin in the brain many years before people have memory problems. Are we going to use these treatments to treat asymptomatic preclinical Alzheimer's? We'll see what the data say, right? Those trials are underway, and we'll see how they look. So let's switch to changes in diagnosis. Now, the plaques and tangles that are Alzheimer's disease are tiny, microscopic, right? I do this, but they're even smaller than that, right? You could only see them on an autopsy. So, if you knew somebody who was diagnosed, maybe 10, 20 years ago, they often had the qualifier of possible or probable Alzheimer's disease. And you would have to wait for an autopsy to be 100% certain to show that they had Alzheimer's in their brain. That might be new information for you, right? Because you don't often hear that kind of thing when you meet with your doctor these days. But there wasn't a way to definitively show that there were plaques and tangles in the brain. That has changed. So we have new technologies that will show us that people have plaques and tangles, amyloid and tau deposition in the brain. And that takes some of the uncertainty of whether a person has Alzheimer's disease out of the equation. So I want to give you a quick overview of them. I'm sorry, my font is a little bit small here, but there are 4 of these. And again, this is just a general overview. But these things either are in your health system or are coming soon, okay? So the first one is what people consider currently the gold standard for determining whether somebody has Alzheimer's disease. It's a specific form of PET scan called amyloid imaging or amyloid PET. So, these scientists have developed a particular radio tracer that they will inject into the person. It circulates into the brain and selectively binds or attaches to those amyloid plaques. You put the person in a PET scanner, and if the person has amyloid plaques, they light up, so to speak. You can see where they are in the brain. You can see how widespread they are. And it is really considered to be the gold standard of whether a person has Alzheimer's pathology in the brain. Right? So when I was talking about these infusion methods, these anti-amyloid treatments, and I said you have to have positive evidence of amyloid in the brain, well, this is considered positive evidence of amyloid in the brain. Right? So whereas we used to have to say, well, to confirm this is Alzheimer's disease, we'd have to wait and look at an autopsy down the road. Now we're doing this in a living brain, right? Again, a remarkable development. This has been around for actually quite some time. The first study I'm aware of that was published on amyloid PET was around 2006, 2007. But the technique and payment for the technique has become much more accessible. So it isn't just for clinical trials anymore. You're seeing people getting amyloid PET before they get those infusion treatments. Second is when people have Alzheimer's pathology in the brain, these plaques and tangles, it affects the amyloid and tau proteins, and those show up in the cerebrospinal fluid. So we'll call it CSF for short. That is the fluid that surrounds your spinal cord and brain and protects it from damage. So it turns out that in addition to amyloid PET, you can extract some cerebrospinal fluid, i.e. spinal tap, right? Take a sampling of that fluid and analyze those proteins, the amyloid and tau proteins, and it is another indicator of whether there's Alzheimer's pathology in the brain. That's also really an impressive development, and it's very helpful for determining whether a person has Alzheimer's disease. Because what happens, if you're not aware, is people will get diagnosed with MCI or a dementia, and then we have to determine the underlying cause. That's why you use these. We'll talk about the role of memory testing and screening in a little bit. The next one is trying to make this a little more accessible. So, I've never done a spinal tap myself, but I think it would be much easier to draw some blood than to set some people up to withdraw cerebrospinal fluid. So for many years, researchers really wanted to develop a blood test for detecting Alzheimer's disease, and frankly, I was very skeptical. I kind of thought this isn't going to happen. A blood test, really? But it has happened. I'm going to tell you about it, two of them very briefly, but as it turns out, is now blood tests are going to become a really important part of diagnosing Alzheimer's disease, which I think is really important, and I actually think incredibly helpful. The last one is genetics, and this one, we could probably talk for 20 minutes on genetics, but I do not have that kind of time. So I'm going to give you a very short version of what's going on with genetics in Alzheimer's disease. 95% of cases of Alzheimer's disease are what we call typical late onset Alzheimer's. Alzheimer's developing in the 70s and 80s and beyond. There is a subset of cases of Alzheimer's disease that are early or young onset and run strongly in families. It's much more rare than the typical type of Alzheimer's that we see, but that form of Alzheimer's disease has 3 genetic mutations associated with it. And if you have a genetic mutation, that means if you live long enough, you're going to get it. For the 95% of cases of Alzheimer's disease that are not this familial young onset type, there have been no identified genetic mutations, only genetic risk factors, right? So what that means, if you have a risk factor, you have you have a higher chance of getting it than if you didn't have the risk factor, but you might live out your days without ever having Alzheimer's disease. So for typical late onset, regular Alzheimer's disease, oftentimes genetic counselors don't really recommend genetic testing because there's not a mutation. There's just a risk factor. So it doesn't tell you whether you're going to get it. But in this early onset that runs in families, there are these mutations, and so that is another potential biomarker or diagnostic tool for whether a person has Alzheimer's. But again, this is a rarer situation for a very specific type of Alzheimer's. Same pathology, plaques and tangles, amyloid and tau. But you need to be aware that in young onset type, they may want to do genetic testing. But if you're talking about Typical Alzheimer's, they probably won't, except for maybe that ApoE4. Okay. That's about all I can say about genetics due to time. So I want to say a couple things about blood tests, because there is a good and a bad with the blood test. First, the bad. I know you can't see this. This is an article from something called Alz Forum. It gives updates on new developments in Alzheimer's disease. And this little article is talking about one company that decided to take their blood tests and directly market it to the consumer. And what that means is they're looking for people who, this is outside of working with their healthcare provider, their physician, nurse practitioner, and basically saying, if you're worried about getting Alzheimer's disease, come and take our blood test. You don't need a doctor's orders. You could just do it on your own. I have very strong feelings about this, right? It is something that I think you should avoid 100%. Not blood tests, but direct-to-consumer marketing of blood tests. Because these tests, not this particular test, have gotten quite good, but some of them have a false positive rate, right? I think after COVID, everybody knows what a false positive is, right? It's when the test says you have it, but you really don't. That can happen with some of these biomarkers, right? It says you have Alzheimer's disease, and you maybe don't. It's a test error. So if a company wants to market this directly to you, that's a problem. You need to work with your doctor. You need to work with your nurse practitioner and make a decision together about whether the blood test makes sense to you. I don't want to pick on this company too much more than I already have. So let me tell you about another blood test. So before last summer, I looked, I keep up with these things, and I thought these blood tests are not ready for rollout in primary care. They just aren't quite accurate enough. The data don't support it. And then last summer, there were data published in one of the prominent medical journals in the world about this new blood test developed by a company working with Washington University in St. Louis. So the test is called Precivity AD2 or Precivity 2AD. And this is a blood test that looks at the ratio of both amyloid and tau in the brain, and it's remarkably accurate. I've said often, I don't often get stopped in my tracks by data related to Alzheimer's disease, and this one stopped me in my tracks. And I thought, that is incredible, because this is a simple blood test that is nearly 90% accurate at telling you whether you have Alzheimer's pathology in the brain. This, to me, is a game changer for how we think about Alzheimer's disease and how we think about the diagnosis, okay? Now, I have no stock in this company or in this. I'm just coming to you as saying the data on this test are good enough that I think you're going to see it quite often as people are getting evaluated for Alzheimer's disease. Now, there are going to be some pros and cons with this, and we're going to talk about that now. So the plus of these new biomarkers is that when people have clear symptoms and they've been evaluated, we're going to talk about screening. When there's a documented problem with memory, these tests can really help us accurately figure out whether it might be Alzheimer's disease or not. And that's a very good thing. It takes some of the uncertainty out, because it will tell you whether it's Alzheimer's disease, but it can also tell you whether it's not, and whether it might be something else that we should be treating differently. That's a good thing. The other thing about it, though, is there's going to be a move, and it's already here, is to start applying some of these biomarkers before people have symptoms. And you might think that sounds like a good thing, and other people think that doesn't sound like a good thing. There's a lot of controversy about this. So it's something we need to think carefully through. But we talked a little bit about this before. One of the things that these biomarkers are going to allow is for detection of Alzheimer's in people who don't have symptoms, who don't yet have symptoms, right? This preclinical Alzheimer's disease. This is a big change that may be coming. So One implication is we can more definitively show that people have these changes in the brain. There's another movement to change the diagnostic criteria to focus more on things like these blood tests to rule in the pathology of Alzheimer's. There's recognition that we could do this, make a diagnosis in Alzheimer's of people who don't have memory problems, right? Now, if we had a surefire way to stop it from progressing, that would be an ideal thing, right? You just say, well, you don't yet have symptoms, but we know it's coming. We think it's coming, so let's stop it. But until we have that, this is going to be controversial, right? Because what we don't know is when somebody has evidence of Alzheimer's pathology in the brain, a positive blood test or an amyloid PET scan, how long will it be before they show symptoms, right? Will they ever show symptoms, right? And so until we know those things, these approaches in asymptomatic people are going to be, fraught with some ethical issues, right? So what does it mean to have a positive amyloid test and you're functioning completely normally, no change? So when I started today, I said we're going to talk through some things that take some thinking through, right? And you have to weigh it in your individual situation. This is one of them. What would be the implications, right? So we don't know when you would develop symptoms or if you will develop symptoms. You've just got this thing in your brain that progresses. What might be some of the risks, right? Would you think it might affect your ability to get long-term care insurance if they know you have Alzheimer's disease in your brain, even if you're functioning normally? How does it affect the way people interpret your behavior? How does it affect your interpretation of your own normally aging forgetfulness, right? I think any of us who are beyond 45 probably know it's harder to remember as you get older. And if you know you have this Alzheimer's pathology, how does that change the interpretation of those everyday forgetting? So when I can't remember your name, is that just normal aging, or now that I've had this blood test, it's a little scarier, right? And do I know it's due to that? So the Alzheimer's Association has suggested that we should use these to confirm potential Alzheimer's diagnosis. Nobody's really recommending directly that we use this before people have symptoms, but there's a bit of mixed messaging there as well, because it can happen. One of the things that there's an international group has recommended that we use this when people have clear symptoms. They've got memory problems, they've been screened, they've been tested. That's a good use for these biomarkers. But what they argue is this third bullet point, I should have put it in big, bold letters, a positive biomarker result, blood test, doesn't guarantee that you'll have dementia, right? You could live many years without symptoms. And the goal of any of these tests should be treatment and prevention, not just understanding what your biomarker status might be. Okay, we need to move through. So when do you get an evaluation? And so when I say evaluation, I mean a clinical evaluation. Get your memory tested, talk to your doctor. When should we start paying attention to these things? This is not related to the biomarker blood test. So anytime there's an abrupt, sudden change, you should definitely check in with your doctor, nurse practitioner. If it's abrupt and sudden, it's probably not Alzheimer's disease, because that comes on slowly and gradually. It's probably something else. When things are gradually getting worse, change in your ability to do everyday activities. You have family history, things are getting worse. Family history alone is not enough to get an evaluation. It's not that strong of a risk factor. But when you put it together with other concerns, maybe that will push you to talk to your doctor. If you worry a lot about memory and dementia, go get screened, go get it checked out. This is an important one. If you have somebody in your family or a friend that you really trust and they say, I think you need to go get it checked out, believe them. Do it. Maybe talk to them about brain health rather than a dementia evaluation, right? We all need brain health checkups. So you can get screened. And in fact, today, you have the opportunity to sign up to get screened. The screening will happen here at this church. Not today. The sign up will happen today. When I finish, right after I finish this talk, you'll get to hear more about how you can have that happen. Screening is designed to determine whether you need more evaluation, not to make a diagnosis. So use the information to make decisions about what's next. Okay. That should lead to a more comprehensive evaluation. We can talk more about that. We need to get moving on prevention. So, one more thing here. Should I push for more evaluation? This is a difficult question. So maybe your loved one has a diagnosis, or you do, and you think, maybe I need more evaluation. So just a few thoughts. So maybe you need more evaluation if you've never had any type of brain scan, CT, MRI. They've never drawn blood or urine to check for reversible things, and it's continuing to get worse, right? Or if the doctor, nurse practitioner has never really listened to your perspective, you're just having these very brief appointments, maybe then it's time to push for more. But the other side of this is sometimes we push for more evaluation because we're having trouble accepting the diagnosis, right? And in those cases, more testing is not going to give you what you want. You know, more testing is not going to take away the situation that's already been established. So you don't have to get biomarkers, you don't have to do these infusions, right? Maybe you've accepted where things are and you're looking more at how do we live with this. We're going to talk about that a bit more in the afternoon. Okay, so one of these points for these biomarkers is that we should be thinking about treatment and prevention. So let's talk about prevention. This is very important. So what do we know about preventing Alzheimer's disease? What do we know about delay, reducing risk? Those are all the same question, actually. So we've known a lot about prevention for a while. In 2010, the National Institutes of Health came out with a statement giving 5 big factors for reducing risk. Heart health, what's good for the heart is good for the brain. Being physically active, eating a healthy diet, being cognitively engaged, and being socially active. Big 5, right? This has not changed. These are all good things. Cognitive engagement, don't have to do little apps, you don't have to do crosswords if you don't like them, but you do need to do something to keep your mind and your brain engaged. All right, The Lancet is a prominent medical journal out of Europe, and they update the science of prevention every few years. Back in 2020, they said 1/3 of cases of dementia could be prevented with lifestyle, and now they've upped that last summer to 45%. So we're going to have another talk today on prevention and healthy living. I just want to make a few points, and then I need to end with a quick story. So we're thinking about lifestyle factors. This is too small for you to see, but it's in your notes. And the only point of this is to show that prevention is a lifelong activity, right? So there are childhood things, so more and better education is associated with lower risk. There are all sorts of midlife things you should be paying attention to, hearing loss, high cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, excessive alcohol. So there are all sorts of things, if you're concerned about Alzheimer's and dementia, that we can be focusing on in a proactive way. When we're looking at late life, we are really thinking more about social activities. So being socially isolated, socially withdrawn, is not good for the brain. So we want to stay active in that way as well. So again, we're going to have a talk on this later, but the point is 45%, right? That's stunning. This is a huge development, right? We shouldn't sit back and wait for these things to happen. We should do everything that we can. So I want to end with a quick story. And so this is actually a pretty well-known case study that was published in a peer-reviewed scientific journal about a woman that they just called Sister Mary. So Sister Mary was born in 1892. Her mother died when she was 12, and so she entered the convent at age 14. She had an 8th grade education, but she started teaching at age 19, and she continued to teach full-time until she was 77, and then went to part-time until she was 84. She was an avid reader, but her vision was low, and so she had to use a magnifying glass to be able to read. She was an avid prayer. She prayed her way around the world using a map and a globe. And she was very concerned with health and wellness issues, especially related to women and girls, so she was donating her body to science. And she said it was the happiest day of her life when she did that. Then came the nun study. So the group of researchers approached the convent and said, we're going to do a study of Alzheimer's disease. What we want from you is to do annual cognitive exams. We're going to take all your lifetime health records from the convent. And then when you pass away, we want to look at your brain on autopsy to look for signs of Alzheimer's disease. And Sister Mary was a leader in the convent, and she was the first one who said, absolutely, sign me up. So this is the data from the cognitive exam, and you can see there's a little dot up in the corner that is Sister Mary. So this plot is performance on a screening test. By age, she was 101 at the time of this, and she was one of the highest scorers in the whole sample. And when they did a full cognitive evaluation on her at age 101, it was completely cognitively normal. Everyone around her recognized that there was no change, but several months after the cognitive evaluation, she passed away. No one noticed anything different other than she got a little bit quiet in the weeks preceding her death. They sent her brain for autopsy. Do you want to guess what it showed? So Sister Mary's brain had widespread plaques and tangles. We said that the plaques and tangles can lead to cell death and shrinkage of the brain tissue. It was one of the lightest brains in the whole sample of the nun study. And by all biologic accounts, she had Alzheimer's disease. Right? When this was first published, it was quite stunning, right? Because it showed that there wasn't a complete one-to-one overlap between the brain and the symptoms. So what does this mean for us, right? So what do we learn from Sister Mary? One, it shows us something about these activities in building cognitive reserve, right? So she continued about her business, she did what was important to her, and she lived her life. The second thing we learn from it is we should use caution with biomarker tests when people don't have symptoms, because she certainly would have had a positive blood test for Alzheimer's. And how might that have changed the way we thought about Sister Mary, who was living her life? Now, I'm out of time, but I do have to give you a huge caution with this, right? So I'm not saying go be Sister Mary, right? If you do these things, you won't get Alzheimer's disease. We are not at that point in prevention. And when we think about these prevention activities, what we're trying to do is lower risk. And it's really important, and this is what I want to end with, is that we don't blame people who have Alzheimer's disease because they didn't live healthy enough. If they would have done the activities, if they would have exercised more, if they didn't smoke, if they didn't drink, they wouldn't have gotten Alzheimer's disease. It's really unfair. We don't have control over whether we get Alzheimer's disease or not. It's not their fault. They're already carrying a very heavy burden. All we're talking about is if you're worried about Alzheimer's, get moving, get active, take proactive steps.
Thank you for listening to this podcast. And please subscribe to this channel if you've not already done so, and leave a review if you found this content helpful.